Welcome to the ESU online education platform, starting with Module 1 on challenges in differential diagnosis of male lower urinary tract symptoms and benign prostatic enlargement. My name is Christian Gratzke. I am a urologist from Freiburg in Germany, and I'm very happy to introduce the first speaker, who is Professor Stavros Grabas from Larissa in Greece. He's a professor of urology, and he's been the chairman of the EU guidelines for male LUTS for many years now. He's one of the most profound experts in male LUTS. So, Professor Grabas, I'll hand it over to you with your presentation.
Thank you very much, Christian, for this kind introduction. Dear colleagues, it's my pleasure to participate in this European School of Urology online educational activity. It is true that we live in the COVID-19 era, but medical education should continue even in a different format. So the topic of my presentation is challenges in differential diagnosis of male LUTS due to benign prostatic enlargement. And this is my potential conflict of interest related to this presentation. So when we talk about differential diagnosis, actually we talk about the assessment. And the critical question is why we need all these tests. Of course, we need to make the differential diagnosis, but there is more than this. We need to predict which patients will progress. We also need to select the right treatment. We need to predict the outcome of the treatment, but also we need to follow our patients and monitor any changes from baselines. 2009 was a landmark year for the guidelines, because we moved from the concept of benign prostatic hyperplasia to the concept of non-neurogenic male LUTS. And this is because we have now the understanding that male LUTS is more than prostate. We know very well that overactive bladder symptoms may occur in men as well. It's not only a privilege of the women. We know from the studies that the incidence of overactive bladder symptoms are comparable in men and women. It increases with age. In addition to that, and to make things even more complicated, we know that people who come to us complaining for LUTS, they report both voiding and storage symptoms in almost half of the cases. And things are even worse, because there are many urological and non-urological conditions or disease that may contribute to the development of male LUTS. Of course, prostate still plays a dominant role in male LUTS pathophysiology, but now we know very well that the etiology of male LUTS can be multifactorial. Therefore, we have several challenges to work with, and another challenge is that we have studies with low level of evidence to support the use of some of the tests. For this, we have some objective difficulties because it's very difficult to run a randomized control trial to evaluate, for example, the use and the role of digital rectal examination or medical history in the assessment of male LUTS. Therefore, the data we use are coming from studies indirectly, studies with different primary endpoints. As a result, most of our recommendations are based on expert opinion. Don't forget that until 2013, the EU guidelines had only one page dedicated to the assessment of male LUTS, this page. And this page in this page, only the available assessment tests were presented without any further recommendation, because it is very challenging. So in order to overcome these challenges, we need, as a first step, to set the goals of the optimal assessment. And the first goal is to make the differential diagnosis, and the second one is to define the clinical profile of men with LUTS who are sitting in front of us at our office. This is very important because based on the findings from the assessment, we will be able to allocate our patients for watchful waiting or medical treatment with one drug or medical treatment with a combination of drugs, or to allocate our patients for an invasive therapy. And if you look at the algorithm, the medical treatment algorithm of the EU guidelines, what we need to know? There are three very important decision points. One, the presence of nocturia polyuria, which type of symptoms is predominant, and third, we need to know the prostate size. And this is something we should know from the assessment of our patients. If you look at the surgical treatment algorithm, then we have some additional decision points. One is, again, the prostate size, but also it is the comorbidities of the patients. If the patients can receive anesthesia, if he can stop antithrombotics, but in addition to that, the patient's preferences and the willingness of the patients to accept some complications specifically related to the specific treatment we will propose. So to overcome all these challenges, the second and biggest step was to develop this diagnostic algorithm. And this algorithm represents a very realistic and practical approach in the management of male LUTS. So in the beginning, we ran some basic tests, including history, symptom score questionnaire, urinalysis, physical examination, PSA, and measurement of PVR in order to get all the necessary information to make the differential diagnosis. For example, from history, we can have additional information regarding comorbidities like diabetes mellitus, neurological diseases, but also information about the current medication of our patient, lifestyle habits, emotional and psychological factors, and the baseline sexual function status of the patient, because some of the treatments, medical or surgical, can affect the sexual function of our patients. It is very important to dedicate time and discuss with our patients and show how much we care about them, to understand the expectations and the preferences of the patients, to inform them and also engage them in the decision-making process. So based on the first 6 tests, we can have all this information to make the differential diagnosis, to exclude and also treat some other potential causes, for example, urinary tract infection, and then we can move and then escalate our diagnostic approach based on the findings from the previous tests. So if we have a patient with bothersome symptoms, then we can ask for the assessment of prostate volume and uroflowmetry. And then if we have predominant storage symptoms or nocturia, we can ask for voiding for bladder diaries. It is also important that the ultimate goal is to reach to this last box where we have a patient suffering from LUTS because of benign conditions of the prostate and or the bladder. And in addition to that, we have the baseline values. We have the clinical profile, meaning the type of symptoms, characteristics of the patients, but also an estimation of the risk of progression. And this is another example what we can get from this diagnostic approach. These are the progression criteria from the MTOM study regarding the likelihood of a patient to progress. We need to know the age. This is easy from the history. We need to know the prostate volume, PSA, Qmax, and PVR. And you can see that we can get all this information from our diagnostic algorithm. So based on these findings, then we can have some additional information regarding comorbidities, sexual function, and the preference of patients. And then we are ready to select, together with our patient, the right treatment for the individual patient who is sitting in front of us. But this is what the guidelines say about the diagnostic approach of men with LUTS. Let's see what happens in real life practice. We have some studies, and you can see that there are discrepancies between real life practice and the guidelines. But also you can see some difference between urologists and general practitioners, but also some difference between urologists from different countries in the number of tests they use for the diagnostic approach and differential diagnosis of male LUTS. And this is something we need to consider. All these differences between the guidelines and clinical practice are because of the lack of high-level evidence studies. There are also differences in perceptions between urologists, but also difference in cost and the availability of the diagnostic tests. There are differences in the reimbursement policy system between countries. There is a number of national and international clinical guidelines, and this may confuse urologists, and also depends on the certainty or the uncertainty of urologists about the origin of the LUTS of the individual patients. So we need to keep updating our guidelines by incorporating new studies like the AMSTRIP studies that has very recently been published. So as in conclusion, it is true that we face several challenges for the diagnostic approach of men with male LUTS. We know very well that male LUTS does not equal to prostate only. Therefore, we need to do the differential diagnosis. It's also true that we need better studies. It is very important to have a stepwise approach to the diagnosis and differential diagnosis of our patients in order to build the clinical profile and select the right treatment. And beyond any discussion, guidelines should be further diffused and implemented in order to have a standardized approach and also to overcome all these challenges. Thank you very much for your attention.
Thank you very much, Stavros, for this brilliant presentation. I think you very clearly showed us the challenges that we face. Can I start with the first question that really strikes me? I see many patients every day, and I usually, when a man comes in for the first time with male LUTS, I like to ask him, what is your main problem? What is bothering you the most? And what would you like me to improve the most? You said this, like setting patient expectations, because I realize that that might be very different from my view. And then I do some treatment and I think it's much better, but the patient actually disagrees. And then we're not getting ahead. Would you agree?
Absolutely, I fully agree. This is a very good point. You know, one of the challenges, because we're talking about challenges that we face in our daily practice, and I know that this is a common problem in Germany, in Greece, in other countries, especially when we are based in public hospitals, that we don't have enough time to spend with our patients. So our appointments are scheduled every 10 or 15 minutes, and this is not enough. So I think that during the first appointment, I think that we need to dedicate more time to discuss with our patients in order to understand the expectations and the preferences of our patients. And beyond the discussion, you know that there are also some cultural differences from country to country. And this is something we need to respect and also to investigate in order to provide the best care to our patients.
That's a very straightforward answer. Can I go forward maybe with a very practical question that I always ask myself? So when you have a patient, and be it through medical treatment or through surgery, you really want to know the prostate size. What is your approach? Do you have to do a transrectal ultrasound every patient? Is a transabdominal ultrasound okay too? Some colleagues even say that the palpation of the prostate, you can estimate prostate size. Can you give us some comments on that?
Yeah, I think this is a good and practical question. And I still remember that we have some hot discussion in our panel about the position of ultrasound examination of the prostate. So it's true that digital rectal examination can be used to assess the prostate volume. However, the correlation to the actual prostate volume is very poor. So I think that the question, if we need, let's say, an accurate measurement of prostate volume in order to allocate our patients for medical or for surgical treatment, is ultrasound examination, transrectal or subabdominal. We know that transrectal is more accurate than transabdominal from studies, but I think that in our daily practice, at least this is my personal experience. I hate to talk about personal experience since we talk about data and guidelines, but I prefer transabdominal ultrasound because you have the additional advantage to also measure the PVR. So you don't use two different probes to estimate the prostate volume.
Great. One of the other problems that we always had long discussions about was the role of the PSA value. So you can actually measure PSA for various reasons in a man with male LUTS. You can measure the PSA because you're still a urologist and you would like to have a comprehensive view on the patient. And of course, PSA in the early diagnosis of prostate cancer is of interest. You can also argue that you would like to have the PSA as an estimation of male LUTS progression. What's your take on this? Do you have to do it? Do you have to do it once? Is it according to prostate cancer guidelines? What do you think?
I think it depends on the age of the patient, and if let's say the diagnosis of prostate cancer can change our practice. So if you have an 85 years old man with a big prostate who needs some kind of intervention from our side, I don't see any reason to do a PSA. But you have a 60-year-old man, a younger man, I think that we should measure PSA, not only to exclude prostate cancer at the moment, but also to follow up our patients. Don't forget that several medical treatments can affect the level of PSA. And also, this is very important when we follow our patients. But let's say, in practical reasons, to use the PSA as a proxy of the prostate volume, I don't see a big room for this, because we have also with the prostate volume measurement using the ultrasound.
That is a good statement for my next question, because it really, you're not using it as a proxy, but many colleagues would like to have some marker that they can use for the progression of the patient. And PSA, to my knowledge, has been established in several studies as a marker for progression. You mentioned the MTOPS criteria, which of course encompass more than just the PSA. Can you give us some hints and guidelines if we would like to see whether the patient, because that's an everyday scenario, patient asks, you know, is surgery necessary, is it not necessary, can I still carry on with medical treatment? What do you do?
I think this is a very good point, Christian, and we have discussed about that several times in the past. You know that guidelines need to follow the available data, but guidelines is not an academic exercise. It's about practical approach of our daily practice. It is about guidance of our colleagues to improve their daily practice. So with respect to the MTOPS criteria regarding progression of BPH, I think that let's be practical. If we have an old man with moderate to severe symptoms, if we know the prostate volume, then we know that if it's a enlarged prostate, then we know that this patient is more likely to progress. So we can discriminate patients who are likely to progress and not to progress, and then we can select the right treatment, because this is in our guidelines, you know, to select maybe combination treatment for patients who are more likely to progress in the future.
Thank you for that. When I read, and you showed the results, when I read the TRIUMPH study, I think it was published in 2006, if I remember correctly, it was published in 2006, but it was really derived from data from 2003 and 4. That's more than 15 years ago. But I still like these parameters, whether they are actually true today or not, because they just show the national differences. But of course, they might be due to economical burden and the different healthcare systems. So do you think these, and they might actually change because reimbursement might change in a country from time to time. Do you think these parameters shown in the TRIUMPH study are still valid today? Would they have changed at all?
I hope they have changed, to be honest, because all these studies were conducted before 2008. You are absolutely right. It's not only the TRIUMPH study, but all the other studies I presented were conducted before 2008, and beyond any discussion, before the introduction of our diagnostic algorithm. So I hope that our diagnostic algorithm has made an impact in our daily practice. But we need to run a new study to prove that. There is a gap in the literature. And I think this is what the guidelines should do, to explore if the guidelines are implemented in daily practice. And it's our task, and I'm very happy with this educational activity to diffuse the guidelines and the data we have in the urological community better than we did in the past.
Yeah, I think that's totally true. And therefore, my just last question is a very practical one. So we spend a lot of time for the guidelines. We try to come up with good recommendations that our colleagues can actually use. So let's say you use this algorithm and you plan treatment as you showed, whether it be medical or surgical. In very many circumstances, it really depends on the doctor's preference. And that's true for the medical treatment or the surgical treatment. You know, for surgery, where you have the most experience, its costs, its availability. So of course, that's important for us to know, right?
That's correct. That's why we need to talk with our patients and understand the expectation. It's not about our personal preferences. It's about the patient's preferences. So the treatment should be tailored to the individual needs. For example, some patients are interested in more durable results, but some other patients are more interested in maybe a minimally invasive therapy in order to preserve their ejaculation. So I think it is about the objective information of our patient and an honest discussion about that, about the availability. Maybe I don't have one of these fancy minimal invasive therapies, but if the patient wants to have something that satisfies his needs, then I can refer this patient to another center. It depends. So it's not about our preferences, it's about the patient's preference. And I think this should be very clear.
I think that's a brilliant conclusion. I mean, what I learned, the older you get, the more you just, listening to patients is what we're here for, to actually be able to help them substantially. Stavros, thank you. I think that was a very nice educational program, and I would like the organizers, the ESU school, and if you have any questions, which I'm sure you have, you're welcome to ask these questions at the next live webinar, January the 19th, 2021. So thank you all again. Thank you, Stavros.
Thank you. It was my pleasure. Thank you very much.